Good morning, everyone. I would like to thank the organizers for giving us the chance to present this topic, genetic syndromes in congenital heart defects. I thank mainly Sabine for this kind of invitation. We have no conflict of interest. This is rather a complex topic because it includes really many things. It's highly heterogeneous, and we know very well that rare disease patients face common problems. And because we're talking here about syndromic patients, and because often there is a lack of access to correct diagnosis, and there's also a delay in making the diagnosis. And when you get the diagnosis, we will have often lack of equality of information and scientific knowledge. And of course, with heavy social consequences for patients and for families. And there are often inequalities and difficulties in access to treatment and care. These are just some examples where we can notice how rare conditions can have delay in diagnosis for months or for years, even after the first presenting symptom. And in this figure, we can notice that sometimes it's the patient or the family that can reach the diagnosis for the whole condition prior to their healthcare professional. So it's often a difficult task just to reach the proper background for these conditions. And as my colleagues have described before, that rare cardiac diseases include mainly inherited cardiac diseases for cardiomyopathies, electrical conditions, and aortopathies, and for congenital heart defects or other rare conditions. And why congenital heart defects? And as Professor Hetz said previously, that it's because it represents 10% of all pediatric mortalities due to congenital heart defects, and 50% of death are secondary to malformations that are CHDs. And we have already seen this, this figure in another way, because we know that there are tens, maybe hundreds of genetic factors and genetic background that can lead to congenital heart defects, including transcription factors, structure, proteins, signaling molecules, etc. But from a practical point of view, our main aim when we see a child with congenital heart defect is to understand, is that a sporadic or is it a familial condition? Is that an isolated non-syndromic condition, or is it a syndromic situation? Because if it is a syndromic, we know that there are a lot of conditions that can lead, or where congenital heart defects makes part of it, and it represents around 30% of all congenital heart defects. So during the first visit at clinical geneticist clinic, we start with history by building the 3 generational pedigrees, just to understand whether this is a kind of Mendelian, there's a Mendelian transmission, or whether it is just a sporadic condition. And then we get pregnancy history, because we know, for example, smoking or maternal diabetes or infections or other conditions can predispose to congenital heart defects. And then we check for birth parameters, developmental milestones, physical examination from head to toes, because there are some kind of red flags that can help us just to understand whether this is just a simple, sporadic, isolated congenital heart defect, or whether this is a syndromic condition. Usually my colleagues call me that I come with a list of the investigations, especially when I go to the intensive care unit, when we see the children there, because we ask usually for multi-organ screening, because otherwise we really cannot give a proper diagnosis or the opportunity, or we cannot be of help for the patient, family, and for the laboratory, of course, to get an orientation towards the diagnosis. So we need often multi-organ screening with the eye, hearing, abdominal ultrasound, brain scan, brain ultrasound for infants. Or sometimes we might ask brain MRI, skeletal survey, or thyroid and liver and renal function tests. You may notice here that on the basis of the congenital heart defects, on the subtype of the congenital heart defects, we start just to get oriented whether this is an isolated condition or whether this is just a syndromic condition. because we often see that the transposition of a great artery is often an isolated condition, while when we see an interruption of the aortic artery or atrioventricular canal, in this case, the genetic association is higher. Just like this, just like in this figure, you may notice that for certain condition, we might see more frequently syndromic situation, and for other subtype of congenital heart defects, it is less frequent to see extracardiac manifestations. This table includes some of the major syndromes that can be associated with congenital heart defects, and the genetic causes, as my colleagues explained in the last sessions, that can be due to chromosomal aneuploidies, copy number variants, monogenic conditions, multifactorial, and by multifactorial, it is the mainly there's the contribution also of epigenetic role. We have heard about it in the last presentation for the physiology of pallor, and these are mainly the isolated non-syndromic parts. So for the chromosomal, we start usually as from the decreasing order of resolution, chromosomal karyotyping, microarray for CNVs, and then single gene mutations with next generation sequencing. So just this is an example how it can be really complex when you see just a septal defect, how the percentage can be different from one condition to another. And I'll start just with a couple of examples regarding the chromosomal abnormalities, and starting by Down syndrome. And it's one of the most frequent aneuploidy, 1/700, and in spite of the increased prenatal diagnosis, however, the prevalence in the general population is not rapidly decreasing. And the percentage of congenital heart defect in this condition is 50%. Mainly it is atrioventricular canal, the balanced one, and then the septal defects. Recently, we have just revised our cohort of patients of 859 patients, and we have classified them into those with typical congenital heart defects and those with atypical congenital heart defects. And we have identified that one of the major causes for cardiac deaths are those patients with univentricular physiology. And in fact, none of our patients with Down syndrome reach the Fontan stage. And this coincides with what is written in literature for 7 or 8 previous studies that showed that it is really hard to make patients with Down syndrome who have univentricular physiology to reach the Fontan stage. You may notice here that we have distributed the mortality for patients with typical congenital heart defects and those with atypical congenital heart defects, but the main cause of mortality in this group are those with univentricular physiology. The other example of chromosomal abnormalities where we can see syndromic condition, this is the example of a girl with increased nuchal translucency in prenatal diagnosis, bicuspid aortic valve, amenorrhea. She's in follow-up by endocrinology unit. And the diagnosis is Turner syndrome. And Turner syndrome is often underestimated because it might be without malformation, or it can be associated in 23% of cases with congenital heart defects, which can be as severe as hypoplastic left heart syndrome, or it can be a mild one with bicuspid aortic valve. At long-term follow-up at our endocrinology unit, we have noticed, and this is also reported in literature, that some of these girls are predisposed to late onset hypertension. So one of the evolving conditions that we must care for in these girls is the late hypertension. Now we're just going to talk about the CNVs. And as Eva had described before, this is rather an important part for the syndromic conditions with the congenital heart defects, because this is, I would like to share with you the case of Jada, who was born in 2007, and at birth she showed pulmonary atresia, ventricular septal defect, and MAPCAS. At surgery, the surgeon noticed absent thymus, post-operative complication with pneumonia, hypocalcemia, feeding difficulties, and predisposition to recurrent infections. So this is a condition with microdeletion 22, velocardiofacial syndrome. And we know that this condition has a prevalence of 1,000 over 400, 1 over 4,000. So it is rather frequent in the general population. And almost 1/4 of these persons, these people, they have normal heart anatomy, and the 75% almost, they have congenital heart defects, which ranges from conotruncal defects to septal defects. There are some reported literature which shows that patients with microdel 22, they might be predisposed to progressive aortic dilatation. However, there are just some sporadic reports. In this very interesting study, there is also it was compared how the difference in hospital mortality between microdeletion 22, other genetic syndromes, and patients without genetic syndromes. And it's rather not different for those with sporadic condition, without genetic condition, and those with microdeletion 22. But the hospital stay of patients with microdeletion 22, it was similar to other genetic condition, because we know that the post-operative complication can be complicated with respiratory and infectious problems. It's important also to remember that the phenotype really changes with time, because when there's a child with microdel 22, it is easier to make the diagnosis. But when they get older, it gets more settled at phenotypic level. And so sometimes we might find a parent who has this condition without a congenital heart defect, but you may see the full-blown picture of the condition of the disease in their child. There is a specific system-by-system basis follow-up, because we know that it can hit any organ of the body. And we know now that the psychiatric problem or the neuropsychiatric disorders is major in these patients, especially after adolescence and when they are older. Another example of a microdeletion is this infant with feeding difficulties, failure to thrive, gastroesophageal reflux, prolonged colic for more than 4 months, chronic constipation, other medical issues, pulmonary stenosis, and the diagnosis is Williams syndrome. Williams syndrome is rarer than the previous condition and caused by deletion on the long arm of chromosome 7, including majorly the elastin gene. And here again, we need a system-by-system follow-up for these patients. And the main or the typical cardiac defects include the supravalvular aortic stenosis, pulmonary stenosis, and it's present, the cardiac involvement is present in around 75% of patients. And however, there are also some atypical conditions that can be noticed. The manifestation of the supravalvular aortic stenosis can be the famous clepsydra appearance, and it can be noticed in some studies 45 and others in 75% of Williams syndrome. And the pulmonary artery stenosis is usually the peripheral one, and it improves with age. But it is very important to remember that in Williams syndrome, when the elastin is involved, that gene is expressed in almost in every artery of the body. So we might also notice that there are some abnormalities because it can hit any artery of the body. That's why it's highly recommended that at least once in the life of these patients, mainly at manifestation, to do an angio imaging, including angio CT or angio MRI for the head and neck, especially because we have noticed in a couple of patients that there are some major involvement. One of the progressive effects of this condition is the hypertension, especially out long term with the growing individuals. The last example of microdeletion is the one that Eva has already talked about. It was about a patient that we have seen in intensive care unit that was admitted with severe dilated cardiomyopathy and atrial septal defect, dysmorphic features. And our colleague has identified the microdeletion of 1p36, which is which can involve multi-organ involvement. But it's very important to remember that this condition can cause the spectrum of congenital heart defects, non-compact left ventricle with or without dilated cardiomyopathy, and the group of Sabine have described potential involvement of the PRDM16 and the aortopathies, because the region includes also the ski gene. So with chromosomal abnormalities in syndromic CHD, we have the major ones, but we have also a lot of subtypes. And it can really include many, many conditions, even private, we call it, conditions. And so it is really difficult to delineate. Including the single gene mutations, the rapid advances is we are noticing more and more growing also new syndromes, or the expanding phenotypes for older known syndromes. And we know, however, in spite of all these advances, that the NGS detection rate for syndromes with congenital heart defects might reach up to 60%. And here we are going just now to share some of the major syndromes that are involved with congenital heart defects, mainly the Noonan syndrome, because it's really one of the most frequent ones, and the mild expression is likely to be overlooked. And it can be de novo, but it's very important just also to look at the parents. And a percentage of patients, they can have normal cardiac anatomy and function. And the most frequent one for congenital heart defects is pulmonary valve stenosis, septal defects, atrioventricular canal. And the other category, which is really the one that can be a major cause for comorbidity and mortality, is the hypertrophic cardiomyopathy. ECG abnormality is documented in the majority of cases, even without the presence of structural heart defects. And the characteristic features are variable, and they can include every organ of the body, and the mental retardation is not a major characteristic, because people, they can have normal cognitive level. It's very important to check for the coagulation defects, because up to 33% of patients, they can have it, especially at preoperative stage when you have a patient that must be operated on. The genes that can cause the Noonan syndrome, there are more than 10 genes, and the total detection rate when you do the panel for the rhizopathy, it can reach up to 90%. So it's really now, it gives us a high satisfaction, I mean. The differential diagnosis for Noonan syndrome include the Leopard, include the Noonan-like syndrome with loose Ana gene, and the CFC, and the most severe one is the Costello syndrome. The genotype or the clinical subgroups of the rhizopathy can be also can have a different distribution in the subtypes of the congenital heart defects, because we know that the classic Noonan syndrome, they have more of the pulmonary stenosis, while the Costello more frequently with cardiomyopathy. Other conditions is Holt-Oram syndrome, Hart-Hunt syndrome, which can be caused, which can show preaxial upper limb defects, congenital heart defects, but also conduction defect. And it's caused in 70% by variants in TBX5, and there's no genotype-phenotype correlation. We have described some years ago the condition of a patient with a variant in TBX5 with tetralogy of Fallot with AST, but normal hands, normal metacarpophalangeal profile, and the molecular characterization showed a gain of function mutation. We know now that in TBX5, it's very important to remember that this gene can cause, is the major gene for Holt-Oram syndrome. However, there are some reports in literature which shows that it can predispose not only to progressive conduction defect in terms of bradyarrhythmia, but it can also predispose to tachyarrhythmias, and also to phenotypes of dilated cardiomyopathy and left ventricular non-compaction. Some other conditions that you may see in your clinics is patient when they have ulnar defects, breast and nipple hypoplasia, genital abnormalities, congenital heart defects, and it is we call it the cousin of the Holt-Oram, which is the ulnar mammary syndrome. Other conditions that can have just a gestaltic diagnosis, when you see patients with this phenotype, with the global delay usually, and heart and hands or lower limbs abnormalities, and this is Cornelia de Lange syndrome. Also, in the clinics of pediatric cardiology, you can also notice patients with shorter stature, mental retardation. It is Kabuki syndrome. And in Kabuki syndrome, we have recently revised the literature and our cohort, and we have identified that they often have left-sided lesions, mainly the aortic rotation with aortic bicuspid aortic valve, but also they can show hypoplastic left heart syndrome. Other defect in the Kabuki syndrome includes septal defects, conotruncal in a decreasing order. Another syndrome which can involve multi-system involvement is Charge syndrome, and it is often the one of the group of children that you see in the intensive care unit, because usually they have failure to thrive, major issues, nutrition, and because they have also the facial nerve palsy, and they can have also the cleft of cleft lip or palate, in addition to all these characteristics that you see. The congenital heart defects that are included in Charge syndrome are a bit different in distribution, because there's a good proportion of conotruncal and then the septal defects. The last example of a condition that I'm going to talk about is heterotaxy. It doesn't give us a high satisfaction from the molecular point of view, because we can diagnose just a low percentage with NGS results, and it includes the condition with abnormal distribution of the thoracoabdominal organs. And in the last years, we have revised our series, and we have identified that in the last years, in accordance with what is written in the literature, that the survival is improving, especially for those category of patients with right atrial isomerism, which the previous descriptions in the last years includes 50% mortality prior to Fontana stage. The part that we would like to share with you is that it's very important to avoid the terms of asplenia and polysplenia in heterotaxy, because this does not reflect the reality and can be misleading for clinicians or for pediatricians, because patients with right atrial isomerism, they can have normal spleen in 32% of patients, so almost 1/3 they can have normal spleen and normal immunological investigations. In another study, we have showed that the infections were in these patients with asplenia, real asplenia, the documented one by ultrasound, that they can show more frequent infections in the first 4 years of life. And when you get a specific prophylactic antibiotics program and immunization program, the morbidity and mortality decreases significantly in this category of patients. So just to conclude, that patients with genetic diagnosis in syndromic congenital heart defects, we need first to see the patient, whole patient, not only the heart. The heart can be a spy for certain complex conditions, but we need also to see the whole body that stays behind the heart of that patient. And we count on multidisciplinary management in these conditions. Thank you for your listening. Thank you.
Thank you very much, Anwar. So now I'm very happy that I did not give clinical details, because I'm not a clinician, so you're much more qualified to give the clinical details for all these syndromes. Very nice overview. Thank you so much. I don't see a question yet. Are there any questions from the audience? Just to let you know, we now have 123 attendants. No question coming up. So I think that was a very, very important point to mention, the head-to-toe investigation, so that also to do this in a multidisciplinary fashion involving a clinical geneticist is really important to finally get to the diagnosis for the patient. I think in the sake of time, we move on to, thank you again, Anwar.
Thank you.